Hey everyone, today we're going to talk about intrarenal disorders. I chose this topic because it is not one of my stronger body systems that I fully understand. So in an attempt to be a better provider in the future for patients, I'm hoping this presentation will be of benefit. To understand intrarenal disorders, we really must first understand the function of the renal system itself. So today, some of our objectives will be focusing on the anatomy and overall function of the kidney. We will then talk about several different types of kidney disorders, their classes, and then we'll focus in on intrarenal disorders. We'll talk about some of the common conditions and manifestations that are associated with them, their signs and symptoms, diagnostics and laboratory testings we'll consider, and then some treatment options. So our kidneys are responsible for filtering our blood by removing waste, maintaining appropriate concentrations of electrolytes, and maintaining an acid-base balance. They also help regulate blood volume and pressure, activate vitamin D, and are responsible for producing erythropoietin. If the kidneys fail, waste products will accumulate in the circulation and a disequilibrium of fluids and electrolytes will occur. Decreased vitamin D activation leads to a decrease in calcium absorption, which results in hypocalcemia. So if we have a decreased production of erythropoietin, we know that's an important factor in the production of red blood cells. This will lead to anemia. Renal failure can be classified into one of three types. Pre-renal, which is where there's an issue with the blood supply to the kidney. This can be caused by hypovolemia from hemorrhage or dehydration, or in atherosclerotic disease, which decreases the blood flow to one or both kidneys. Intrarenal, where the cause of failure is coming from within the kidney itself, or postrenal failure, which is involved in the collecting system, such as the ureters, the bladder, and the urethra, which you can see over there in that picture. So obstruction by kidney stones or a tumor would be an example of postrenal failure. But for our purpose, we're going to talk about intrarenal, the problem inside the kidney. So let's talk about the nephron. If we take a close look inside the kidney, we can visualize a nephron, the functional unit of the kidney. You can see it here on the right-hand side when we zoom in. Our nephron is responsible for filtering water-soluble substances from the blood, reabsorption of filtered nutrients, water and electrolytes, and the secretion of waste or excess substances into the filtrate. Each nephron contains a glomerulus, which includes the capillary tuft and Bowman capsule, and a tubule, which includes the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and finally the collecting duct. The glomerulus filters fluid from the blood into the Bowman capsule. The proximal convoluted tubule then transports 2/3 of the filtered water and electrolytes from filtrate into the interstitium. The descending loop of Henle also transports water and delivers a concentrated filtrate to the ascending loop of Henle, which then transports sodium, potassium, and chloride, and it produces a hypoosmotic filtrate and a high interstitial osmolality. The distal convoluted tubule is then responsible for transporting sodium and chloride, water and urea. It is responsive to aldosterone and regulating of the glomerular filtration rate and secrete hydrogen and potassium. Finally, the collecting tubule passively transports water under the influence of antidiuretic hormone, aka ADH, and secretes hydrogen and potassium. So if we put all of these things together, the nephrons inside the kidneys are very important to our body function. Now that we understand what responsibility our kidneys have, we can dive into disorders of the intrarenal origination. There are many types of intrarenal disorders that have potential to cause chronic kidney disease or end-stage kidney disease. These are categorized as congenital, neoplastic, infectious, obstructive, and glomerular. Congenital is where one or both kidneys did not properly develop. They may be identified at birth or manifest later in life. Renal agenesis, a cystic disease, and cystic disease are both common examples of congenital diseases. Neoplastic, which may be benign or malignant tumors. Since the kidney is encased in a tough fibrous capsule, the growing tumor will distort the shape of the kidney, which will hinder its ability to function properly. Infectious bacteria of the kidney, aka pyelonephritis, affects the upper urinary tract, including the renal tubules, pelvis, and calyces. E. coli, Enterobacter, Enterococcus, Proteus, Moralibus, Klebsiella, those are some of the most common causative agents of renal infections. Obstruction is another possible intrarenal disorder. It can be caused by congenital deformities or acquired. Prolonged obstruction in like a post-renal condition, such as a stone blocking a ureter, can lead to an intrarenal acute kidney injury from urine backing up, so to speak, into the kidney. Glomerular disorders, also known as glomerulopathies, result from alterations in the structure and function of the glomerular capillary circulation. Oftentimes, this is the cause of end-stage renal disease. Renal agenesis means a failure of one or both kidneys to embryonically develop, whereas renal hypoplasia is a condition in which the kidney has had some fetal development but still ended up smaller than normal. If a fetus is born with bilateral renal agenesis, it will die shortly thereafter or will be stillborn. If a fetus is born with congenital renal hypoplasia, it increases the risk of chronic kidney disease. Once renal hypoplasia has been identified, regular monitoring of kidney function is recommended. Congenital abnormalities. So let's talk about cystic kidney disease. This is where the kidney has fluid-filled dilations, which may be present at birth or only seen later in life. These fluid-filled areas may be seen as groupings in one area or diffuse. They can affect one kidney or both kidneys. They might be present with other anomalies and occur mostly in men. Renal cysts have been reportedly identified in more than half of patients over the age of 50. So age is also playing a part. The two most common forms of cystic disease are autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. Recessive is usually diagnosed in infants and young children, whereas the autosomal dominant may not be apparent until adulthood. If we compare the features of both, we will see that autosomal recessive shows symmetrically enlarged kidneys, whereas the autosomal dominant will have asymmetric enlarged kidneys, so they don't have the same size or shape. If we take a look at the cysts under a microscope, we will see that autosomal recessive polycystic kidney disease is made up of epithelial cells from the collecting ducts. Now, if you take an autosomal dominant, it will affect the entire nephron. Another feature is that autosomal dominant will have cysts in other parts of their body, such as in their abdominal organs. They may also have aneurysms, abnormal cardiac valves, hernias, diverticuli, where autosomal recessive has none of these. So upon examination of the infant with an autosomal recessive polycystic kidney disease, the most common clinical sign is the respiratory distress or kidneys that are palpable. They will also typically have severe systemic hypertension. Pain is the most common complaint from patients with autosomal dominant, and the pain may be caused from bleeding within the kidney, movement of kidney stones, or the development of a urinary tract infection. The stasis of urine because of the cyst puts the patient at higher risk of kidney stones and infections. Diagnosis is typically made with imaging studies along with genetic testing. Treatment is mainly supportive. So that might include blood pressure control and some pain management. Once the patient has entered end-stage renal disease, they will need to be put on dialysis and should be put on the list for a kidney transplant. So let's talk about some neoplasms. Neoplasms can be found in the kidney. They might be benign, they might be malignant. Often, benign renal neoplasms are found incidentally from an abdominal imaging ordered for maybe other reasons. If they're sufficient size, they may be detected with abdominal palpation. They can produce flank pain and hematuria. Treatment typically involves removal of some or all of the kidney. They have the potential to undergo malignant changes, so they really should be removed. Most kidney cancers are renal cell carcinomas and are mostly seen in men, or I should say they have higher rates in men, African Americans, and along with older adults. There are risk factors associated. Those include cigarette smoking, always cigarette smoking it seems like, obesity, high blood pressure, diabetes, asbestos exposure, women who've had lots of children, long-term renal dialysis, and kidney transplants. Patients don't present with symptoms until the cancer is quite advanced. If we look at the picture, it shows how to stage renal cell carcinoma. So in the first stage, the tumor remains encapsulated. Then the second stage, the tumor begins to invade the perirenal fat. Third stage, the tumor has extended into the renal vein or regional lymphatics. And finally, the fourth stage is when it has metastasized to other organs. Clinical manifestations include costovertebral angle tenderness, CVA tenderness, hematuria, and a palpable abdominal mass. Shortness of breath, cough, bone pain, those don't develop until it has metastasized. Treatment includes a partial to a full nephrectomy, removal of that kidney. And fortunately with treatment, the 5-year survival rate is up to 70%. That's pretty awesome. Nephroblastoma, aka Will's tumor, is the 5th most common malignancy in pediatrics and is the most common cause of kidney cancer. 75% of these cases occur in children less than 5 years old. It's typically only in one kidney. In about 80% of cases, a palpable abdominal mass is found on your clinical exam. Other manifestations might include abdominal pain, high blood pressure, hematuria, along with lower extremity edema. Most often, the tumor is identified by the parents or during a routine physical exam. So you'll want to get a renal ultrasound or a CT. It's typically sufficient for a diagnosis. Treatment would involve removing the affected kidney. It has a cure rate of up to 90%. So if we're working in pediatrics, we need to be watching out for these. Sometimes radiation therapy as well will be used to shrink the tumor before they remove it if the tumor is very large. Some food for thought. Okay, let's move on to infection, pyelonephritis. So typically the acidic pH and urea found in urine produces a hostile environment for bacteria to grow in. It is possible for the blood or lymphatic system to deliver a bacteria to the kidneys, but most likely it came from a lower urinary tract infection. The most common causative agents we see, E. coli, Enterobacter, Enterococcus, Proteus, Mirabilis, Klebsiella, STIs, fungal infections, and mycoplasmas. They might be seen, but mycoplasmas are less common. So risk factors for a urinary tract infection include increasing age, I can't ever say this word, vesicoureteral reflux. Congenital anatomical anomalies of the urinary tract, being a female, being pregnant, using a diaphragm, having a neutrogenic bladder, instruments being put into the urinary tract like a catheter, glucocorticoids, AIDS, diabetes, obesity, and sickle cell traits. Some clinical manifestations of acute pyelo are sudden, may include fever, chills, CVA, tenderness, dysuria, and urgency, and frequency of urination. Chronic pyelo symptoms may be more vague or similar to that of acute pyelo. Diagnosis is suggested by UA results or urinalysis results. Presence of significant bacteria and white blood cell casts will be seen. Imaging, you'll see maybe some scarring to one or both kidneys that are smaller than normal, and they may be distorted. So treatment of pyelo typically includes an antimicrobial therapy for 7 to 10 days. If septicemia is present, the patient may need to be hospitalized for management of their blood pressures while they're undergoing like IV antibiotics. So the next part is obstruction. Oh, I don't want that. Is obstruction. Obstructive disorders interfere with urine flow and it can occur at any point in the renal system, from the renal pelvis to the urethral meatus. So obstruction may be congenital or acquired. Congenital are typically seen in children due to anatomic abnormalities from birth that involve the ureteral valve strictures of the urethral meatus or stenosis at the ureterovesical or ureteral pelvic junction. Acquired includes renal calculi and tumor growth. Once an obstruction happens, you'll have stasis of urine. The structures proximal to the obstruction site will begin to dilate, and the more distal to the obstruction, the less dilation is seen because the pressure is distributed over a greater surface area. Complete obstruction of a ureter results in its dilation called hydroureter. When the renal pelvis and tubules enlarge with the increased pressure, the kidney becomes enlarged. You then have hydronephrosis. Glomerular filtration rate and renal perfusions decline, and eventually the kidney and portions thereof become ischemic. With prolonged obstruction, you have postrenal acute kidney injuries. Those can relate to the tubular necrosis, infection, sepsis, acute kidney injury, and potentially chronic kidney disease can result if this obstruction is not relieved. Partial obstructions are much more common. In this situation, the renal pelvis may become very dilated, but the structural or functional disruption of the kidney may be minimal. If the obstruction is bilateral, however, clinical manifestations of fluid retention will be present. So people will be complaining about weight gain, headaches, maybe increased abdominal girth, ankle edema, nausea, and anorexia as well. So renal calculi or lithiasis is derived from the Greek word stone. They are crystal aggregates composed of organic and inorganic material that are located within the urinary tract and can form obstructions. They can form within the kidney, the tubules, or in the collecting system. They can migrate to more distal structures. The risk of nephrolithiasis is lowest among Mexican Americans and African Americans, and those who have reduced fluid intake, dehydration, increased urine concentration, or decreased urine volume will increase the risk of their stone formation as well. Occupation has also been identified as a possible risk. So those who have increased exposure to high temperatures or a sedentary lifestyle are at greater risk. Stones are uncommon before the age of 20, but their peak onset is between 20 and 30 years old. Some clinical manifestations, they're going to differ depending on the location of where the stone is at. Pain may be vague, or more commonly, you'll see acute renal colic and people will be complaining of flank pain. Stones within the kidney responsible for flank pain may be described as dull and localized, while the stones move to the ureteropelvic junction down into the ureter, spasmodic, intermittent, sharp pain develops. This is renal colic. The patient may develop nausea, vomiting, diaphoresis, tachycardia, and tachypnea. Once the stone reaches the bladder, the patient usually reports significant relief in pain. And patients with frequent recurrent stones may develop scar tissue within the kidney, and this may develop into a chronic kidney disease if it continues. In addition to the clinical manifestations, so you'll want to gather a thorough family history. So risk factors for nephrolithiasis and any anatomical or functional urinary tract anomalies should be identified. Urinalysis will identify infection, levels of specific stone-forming constituents, and urinary pH, which will affect crystallization. Hematuria may or may not be present. Once the stone is passed, collection and analyzation of the stone for evidence of its composition will be helpful for future prevention strategies. A complete blood count or CBC measurements of levels of serum electrolytes, serum creatinine, blood urea nitrogen, and assessment of parathyroid hormone level will provide good information related to additional risk factors and renal function. CT scans are the preferred imaging for identifying renal calculi, along with any other potential sources of flank pain and anatomic anomalies. X-rays, well, they're only able to identify stones that are radio opaque, making them less desirable in this situation. Come on. Treatment of nephrolithiasis might be medical management or surgical. It really depends on the size, the position, and the composition of the calculus, the presence or absence of a UTI, and the involvement of one or both kidneys. The goal of treatment is to treat existing stones and to prevent their recurrence. General interventions for acute nephrolithiasis include narcotic analgesics for pain. You'll want to increase their fluid intake to more than 2 liters per day, orally and IV. Antimicrobials if there is a UTI present. You could use shock wave lithotripsy to break up the stones. Sometimes ureteral stenting is necessary, or ureteroscopy for removal of those larger stones that are not able to pass spontaneously on their own. Some dietary modifications may include adequate dietary calcium intake. They'll want to avoid foods with additional vitamin D, avoiding calcium-based antacids, aka TUMS. Limit your intake of coffee, tea, or cola to less than 2 a day. Reduce protein intake from meat, fish, and poultry. Limit dietary sodium and oxalate intake, and avoid high purine foods for uric acid forming stones. So medications will be unique to the type of stone. So if you have a uric acid forming stone, you might give allopurinol. So it'll just depend. Glomerular disorders, also known as glomerulopathies, result from alterations in the structure and function of the glomerular capillary circulation. So there are 3 layers of the membranes of glomerular capillaries: the endothelium, the basement membrane, and a layer of specialized epithelial cells with foot-like projections called podocytes that encircle the basement membrane. Together, this triple layer comprises the filtration barrier of the glomerulus. The glomerular filtrate passes through gaps called slit pores and between the podocytes, which enters the space of the Bowman capsule, which will then progress into the proximal tubule. Glomerulopathies are responsible for a great majority of cases of end-stage renal disorder, and unfortunately, the specific causes are unknown. They may happen acutely or progress over the course of months or years. There are some implications of hereditary and environmental risk factors. The specific location and features of the glomerular injury will be used to classify the disease. It may be considered diffuse, which includes all of the glomeruli, or focal, which is some, but not all of the glomeruli. Within the affected glomeruli, lesions may be global, which will affect all parts of the glomerulus, or present in patches, which is called segmental. And then sclerotic changes will refer to scarring attributable to persistent or recurrent injury. Okay, so I'd like to take the last few minutes here to talk about nephrotic syndrome. So nephrotic syndrome is a glomerulopathy in which there is a urinary elimination of greater than 3 to 3.5 grams of protein per day due to glomerular leakiness. So ultimately, most patients will develop nephrotic syndrome manifestations, which include hypoalbuminemia, hyperlipidemia, generalized edema, and a propensity for developing clots. The most primary causes are lipid or lipoid nephrosis, idiopathic focal segmental glomululosclerosis, and membranous nephropathy. Woo! I'm having a hard time now. There's also some systemic diseases such as systemic lupus and Hennig-Schönlein purpura, as well as infections, malignancies, and vasculitis. They've all been found to be associated with nephrotic syndrome, but overall, the most common cause associated is diabetes. So the pathophysiology of nephrotic syndrome is increased permeability of the glomerular membrane. It allows large quantities of proteins to leave the bloodstream and exit the body in the urine. So this will produce hypoalbuminemia and proteinuria. The low serum albumin concentration serves to stimulate the liver to increase production of various substances, including lipoproteins, and this will produce hyperlipidemia. Levels of total cholesterol and low-density lipoproteins are elevated. Lipid casts and fat droplets may also appear in the urine. Oval fat bodies, epithelial cells from the tubules may also be sloughed. And there is an increased risk of thrombotic events in nephrotic syndrome related to the stimulation of the hepatic synthesis of clotting factors. So treatment for nephrotic syndrome is generally treated with drugs to reduce the immune injury and inflammation, like corticosteroids. And then elevated lipid levels are just routinely treated with lipid-lowering therapy. Angiotensin II receptor blockers or angiotensin-converting enzyme inhibitors may reduce intraglomerular pressure and reduce a protein loss, as well as treat the systemic hypertension. So I hope everybody enjoyed my presentation. Thank you so much for watching it. I appreciate it. Bye, everyone.